Okay, this is Meconium aspiration syndrome is a very tricky diagnosis, and I'm throwing this in as part of the neonatal pathology that you see, and you'll be called for because it's one of those disorders of newborn transition. Okay, similar to the disorder of newborn transition, the first one, the transient to give of the newborn, this one carries a little bit more, I should say, risks because the morbidity is a little bit higher, and consequences can sometimes be catastrophic. Okay, so having said that, I would like to present you the objectives of the next hour of talk. What we will do is we will review the significance of, I abbreviated it as MSAF, meaning meconium stained amniotic fluid. Okay, very different from MAS, which is meconium aspiration syndrome. Okay, so we're going to go over the pathophysiology of meconium aspiration syndrome. What are the risk factors for meconium aspiration syndrome? What are the neonatal consequences of this disease? How we manage it? And then briefly review the NRP guidelines in the management of meconium stained amniotic fluid in labor and delivery. Okay, so again, these are my abbreviations. I kind of defined them already. So MSAF, stained amniotic fluid. AS is the aspiration syndrome from meconium. I like this. This is kind of cute because I don't speak Greek and I don't write Greek, but this word meconium came from a Greek word for poppy juice or opium. And the reason why this came about is that the sedative effects on the unborn infant of this particular substance explain why the sticky dark green material from the fetal intestine is called meconium, because a lot of these babies will kind of, you know, the sedative effect may kind of like give them a reminder of how these babies from meconium aspiration syndrome are relatively sicker in presentation. Okay, so a quick review of what meconium is before we go into the pathology itself. Meconium is first seen in the fetal intestine during the 3rd month of gestation. That's very early. Okay, first trimester. By the end of or tail end of the first trimester, there's already the beginning of fetal poop, which is meconium. Okay, meconium is a sterile, it's thick, it's blackish green, even though people say, oh, it's black. It's not black, it's really dark green. And it's due to the bile pigments. It's odorless unless there's an infection, prolonged rupture of membrane. And some of these babies will poop and they say, oh, it's so stinky, you know, but in general, if it's, you know, the stool, the meconium of babies who are not sick, no infection, is really odorless. It collects in the distal small intestine and the colon. So what is it? It's mainly whatever in the intestinal secretions, anything that the baby swallows, bile, desquamated cells from the baby's skin, you know, the hair, the lanugo, desquamation from the lining of the intestinal tract, fatty material from the vernix, and then everything else, like as I've said, from the amniotic fluid that the baby swallows, everything collects in the baby's gut. So it comprises of mainly water, and it contains cholesterol and its precursors like lipids, enzymes, including pancreatic phospholipase, some protein, but this decreases throughout gestation, the bile acids and the salts, as well as drug metabolites that the mom is given. 94% of newborns will pass meconium within the first 24 hours of life. That's why, you know, babies who are early discharged, we don't send them home until they poop, okay? So this delayed passage of meconium may not necessarily correlate with the pulmonary disease of babies. okay? Or early passage, I mean, yeah. But delayed passage may be seen in preterm infants because either their rectal sphincter reflexes may be immature, or it could be absent, or it could be impaired, okay? In general, prior to the last month of pregnancy, like before 36 weeks gestation, you hardly will see babies or fetuses passing meconium in utero. They're not supposed to do that in utero, but they will do that if they're in trouble, meaning they're under a lot of stress. There's fetal distress, decelerations. Because when that happens, the rectal sphincteric reflexes will relax, and then whatever meconium is in the colon will just come out and pass through the anal opening, okay? And that's when the meconium finds its way into the amniotic fluid. And when babies are hypoxic in utero, they start gasping. And so whatever amniotic fluid is in the, whatever meconium is in the amniotic fluid, when they gasp, they may aspirate that fluid. And that's the beginning of this meconium aspiration phenomenon. What's the scope of the problem? Now, like as I've said, gestational age plays a role in when meconium is passed in utero, okay? Now, about 10 to 18% of deliveries in the United States will have meconium-stained amniotic fluid. It doesn't mean that all of these babies will have meconium aspiration syndrome, but it just means that there is a setting for this problem to be magnified because of this delivery. Because 85% of babies, up to 90%, will be born full term. So 85, 100 minus 85 is about 10, 15. So those preemies are the ones who will not present with meconium-stained amniotic fluid unless they are stressed in utero, okay? Majority of these are from full-term deliveries. 7 to 22% of full-term deliveries overall will have a meconium-stained amniotic fluid. Even higher numbers if they are post-dates or post-mature, because again, they're ready to be born, they have a rectal sphincter that is mature, and it's not a good setting anymore for them to be inside the womb, and there's a higher incidence of hypoxia in utero as the baby reaches past the due date, okay? Because the amniotic fluid, I mean the placental blood supply is no longer healthy, and there will be less restriction. There will be more restriction of blood flow going to the baby, not just oxygen, but not just nutrition, but also oxygen, and creates a hypoxic picture and leads to the relaxation of the sphincter, rectal sphincter if the baby's hypoxic, and then release of meconium, okay? It's been associated with reduced amniotic fluid index, meaning the moms who are oligohydramnios, okay? Or reduced middle cerebral artery pulsatility index, which suggests that there's some component of blood flow and even the risk for hypoxia in utero. Moms who are sick, those with choreo, maternal fever, and those moms who abuse drugs, opiates, or cocaine use, okay? Or in the setting where, like for example, cord around the neck, nuchal cord, where it may lead to variable decels or even late deceleration sometimes, and also in post-date pregnancies, meaning the fetus might become hypoxic, and therefore the release of meconium through a relaxed rectal sphincter, okay? Only about 3 to 6% of infants born with meconium-stained amniotic fluid will develop meconium aspiration syndrome. So these numbers get smaller and smaller from those high numbers with meconium-stained amniotic fluid, and therefore meconium aspiration syndrome doesn't seem to be a lot, but we still see it depending on the patient population that you take care of in whatever clinical settings you work at. Like at the university hospitals, we saw a lot of meconium. It's like every other pregnant woman delivering has meconium stained amniotic fluid, because there's a lot of drug abuse, there's a lot of no prenatal care, and there's a lot of moms, they didn't even know they're pregnant and they're past their due dates, and therefore they'll come with all this picture, okay? Meanwhile, you're in a suburban hospital where all your moms are have prenatal care, you will see less and less of this because they all had good care, obstetric care, okay? About 30% of those babies with meconium aspiration, okay, will require some sort of mechanical ventilatory support. Okay, we'll talk about that a little bit later. 11% will develop pneumothorax. That's high. Usually the incidence of pneumothorax is about less than 1% of all deliveries. So this is like 10 times more at risk. And there is a mortality up to about 3 to 5% overall, although in some studies can reach as high as 10%, okay? It accounts for 2% of all perinatal deaths. So it's a significant disease that should be taken care of, considered seriously, and managed proactively. All right, so this particular slide shows the frequency of meconium stained amniotic fluid. As you will see, on the left column here is the gestational age in weeks, from 37 to greater than 42 weeks, and then the percentage of meconium stained amniotic fluid on the right column. So at 37 weeks, 3%. Remember I told you it's probably 0.5% incidence of meconium stained amniotic fluid if a baby is born below 36 weeks gestation. But it goes up in number as the baby matures, to the point that at 40 weeks, it's 13% at due date. And then at post dates, up to 42 weeks, it reaches to like 18%, okay? So the more mature the pregnancy, the higher the incidence or frequency of meconium stained amniotic fluid. How do we define meconium stained amniotic fluid? All babies with meconium aspiration syndrome. All babies with meconium aspiration syndrome are in respiratory distress, okay? Meaning, if a baby is not in distress, you won't even consider meconium aspiration syndrome if they're not having respiratory symptoms like tachypnea or retractions or grunting or cyanosis, okay? But this is in the setting of meconium stained amniotic fluid. So meaning in the delivery room, if you see a baby, if you were called for meconium delivery, there's meconium stained amniotic fluid and the baby's in distress, the baby is presumed to have meconium aspiration syndrome until proven otherwise. And this will usually present within the first 4 hours after birth. When they are in distress, they need oxygen, and of course the chest X-ray will be taken in any newborn with respiratory distress, and it will show the characteristic features of meconium aspiration syndrome. Okay, another set of authors defined this meconium aspiration syndrome and categorize it into mild, moderate, and severe, okay? So again, in the presence of meconium stained amniotic fluid, an infant with respiratory distress has meconium aspiration syndrome if you cannot explain it any other way. Okay, and it's considered mild if the baby is requiring non-invasive support, less than 40% oxygen. This is pretty much your typical picture of a baby with TTN, okay? And I mentioned this earlier in the first talk that some of those mild meconium aspiration syndrome could be just transient tachypnea of the newborn babies, okay? Because they improve within 48 hours, okay? But in the difference here is that there's meconium stained amniotic fluid. That's why we think they have aspirated meconium stained amniotic fluid. That explains their oxygen requirement and their symptoms, okay? Now, the second category is your moderate meconium aspiration syndrome babies, and they require this time more than 40% oxygen, and they will require it longer period of time. Now, in this particular instance, They may require maybe a little bit of cannula or a little bit of CPAP, because usually when we administer 40% of oxygen or greater, a cannula will need to be escalated to a higher level of support, like an IMV or even CPAP. And then in the severe form of meconium aspiration syndrome, these are the ones will require assisted mechanical ventilation, and they may get intubated. And these are the ones associated with persistent pulmonary hypertension, or PPHN. Okay. Of note, the severity of meconium aspiration syndrome does not necessarily correspond to the degree of the chest X-ray abnormality, meaning the chest X-ray may not be as bad to say that the baby has severe meconium aspiration syndrome. Okay. So how does it present in addition to the meconium stain amniotic fluid? Most of these babies will generate low APGAR scores because they're kind of like depressed, they're hypoxic, they're sick, they've been in utero compromised for all those late decelerations. Okay. Most of these babies are post-mature, as I mentioned earlier, and they have visible staining of their nails, their skin, and their umbilical cord with meconium. Okay, they're in respiratory distress, they're tachypnic, they have retractions, subcostal, intercostal. They require oxygen because of cyanosis. They have lung overinflation, which present as barrel chesting. They have coarse breath sounds, rhonchi and rales, and their perfusion is poor. Their respiratory distress may persist with prolonged oxygen requirement for days. The shorter course are usually TTN more than meconium aspiration syndrome, and these are the ones who will require less oxygen and will resolve within 48 hours. These are examples of X-rays of babies with meconium aspiration. Okay, this in A, it's an intubated baby. As you can see, there's a lot of fluffy densities on both sides. You can hardly see the border of the heart. Okay, the one on B, you have a lot more aeration. There's a lot of fluffiness, bilateral streaks. Again, this one, you cannot even distinguish this from a TTN or a severe TTN or a bad TTN. And then on C, you can see that there's so much meconium aspiration that a lot of these air sacs are already atelectatic or collapsed, but you can see that on the left lung, you can see a lot of these fluffy densities. Okay, this is an intubated baby. And clinically, you see a baby covered with meconium, very scrawny looking, thin, thick-skinned, wrinkled, because as they reach post-maturity, they become more scrawny looking because they are now using their storage products, glycogen, as fuel, because the placenta is no longer supporting them nutritionally, and it's starting to involute. So the chest X-ray, the severity in meconium aspiration syndrome does not necessarily correspond to the degree of chest X-ray abnormality, as I mentioned earlier. Okay, different descriptions of X-rays of MAS are: you see coarse, patchy infiltrates. There's some consolidation, particularly when you have a lot of atelectasis or collapsed alveoli. There may be some pleural effusions. Air leaks or pneumothorax, pneumodiastinum, they're very common. Like as I've said, 10 times the usual average incidence of pneumos. They can be hyperinflated, particularly early on. They may have a wet lung picture like in a TTN, or hypovascularity, particularly when you're dealing with babies with severe PPHN. In some cases, some chest X-ray may be interpreted as normal, depending on how high your respiratory support is and how mild the disease is. Okay. Some differential diagnosis, what can be confused or what you should consider as possible diagnosis other than meconium aspiration syndrome. I mentioned TTN, particularly in the mild form, okay? Or babies who aspirate amniotic fluid that may not have meconium stain, or blood, like in abruptia placenta. There's blood in the amniotic fluid. Babies with RDS, because some babies are not necessarily all full term to have meconium aspiration syndrome. Those babies born below 37 weeks, subjected to a lot of stress in utero, may pass meconium in utero, and they may aspirate it too, and that complicates their pulmonary surfactant deficiency. In sepsis with pulmonary edema, or babies born with congenital pneumonia, congenital heart disease because of the respiratory distress component, depending on like what shunts are happening, but this is less likely to be higher on the list for me. Interpartum asphyxia with cardiomyopathy, PPHN, and then delayed transition, which is pretty much back to TTN, okay? Delayed transition to me should not last more than 6 hours, okay? But if it's lasting more than 6 hours and there's still some mild distress, it's probably TTN more than your delayed transition. Another X-ray, this is in a post-mature baby with meconium aspiration syndrome. Again, intubated. Look at all these fluffy densities of aspirated meconium. No air leak. This is a milder one, similar to your TTN picture. Interlobar fissure, streaks perihilarly. Consolidations, right upper lobe here, okay, which goes to show there are uneven or asymmetric densities that lead to this is a hyperinflated lung, because if you count the number of ribs, 1, 2, 3, 4, 5, 6, 7, 8, 9, and then you have this very dark part of the lung here at the bases where there's unequal ventilation perfusion, VQ mismatch. Some lungs are more inflated than others. It's not uniform. So, so what happens in the pathophysiologic tree? You have meconium in the tracheobronchial tree. Baby aspirates it. It either leads to airway obstruction, that leads to air block, that leads to ventilation perfusion, okay? Or meconium in the air spaces will lead to surfactant inactivation that will lead to atelectasis. Or there's chemical pneumonitis and there's inflammation that leads to atelectasis. And then the common path will be your ventilation perfusion mismatch. The baby will become hypoxemic or acidotic, and then pulmonary hypertension develop, okay? Mechanisms that play a role in the development of meconium aspiration syndrome, plenty, okay? So in meconium aspiration syndrome, not only you have initially an airway obstruction that leads to altered mechanics of ventilation, you have surfactant dysfunction. You have direct toxicity by meconium constituents. Pulmonary vasoconstriction due to components of meconium leads to pulmonary hypertension. Altered pulmonary vasoreactivity, inflammation and edema. Hypoxemia in utero that leads to vascular remodeling and lung parenchymal changes. And some of the airway resistance and decreased compliance, okay? Effects of mediators like cytokines. All of these play a role in the bigger picture of meconium aspiration syndrome. So we will split meconium aspiration syndrome into two. The initial one where the mechanical effects predominate, okay? Aspirated meconium may partially or completely obstruct the smaller airways. Particulate meconium. Now, partial obstruction will create what we call a ball valve phenomenon that will lead to air trapping and hyperinflation of certain lung fields. This is where you're setting for a pneumothorax that may occur. Now, the meconium will lead to, the obstruction and the meconium presence may lead to cellular necrosis within 48 hours. This ventilation perfusion mismatch that we describe in our diagnosis 3 will lead to your hypoxemia and fall in PaO2. Now, in a situation where you have a lot of meconium completely obstructing the smaller airways, there will be a lot more atelectasis than hyperinflation, okay? But nevertheless, this inflammatory response due to the presence of meconium materials in the air spaces will be what will predominate in the pathophysiologic tree. So this is the ball valve effect. In A, you have that meconium ball in the airway. You provide, the baby breathes, okay, sorry. Or you're intubated and air goes in. Now, as air bypasses this meconium plug here, okay, to ventilate the alveoli, during exhalation, this airway may collapse and will completely obstruct the lumen. So where will the air go? It will just stay in the air spaces, and Pathophysiologic resistance will go to a part of the lung that may eventually rupture and lead to a pneumothorax. Okay, so this is a ball valve phenomenon that we see in the initial phase of meconium aspiration syndrome. These mechanical effects will create direct damage on the alveolar cells. A rise in functional residual capacity will lead to an increase in pulmonary vascular resistance. If you do the echo on these babies, you will see right to left shunting across the ductus and the PFO, and this exacerbates hypoxemia. So this chronic hypoxia will lead to an increase in pulmonary vascular resistance, and this is what we see clinically as persistent pulmonary hypertension of the newborn. And the echocardiogram will clearly support this diagnosis. The second one is the chemical effects of meconium. And this is predominantly summarized in one thing: surfactant inactivation or a functional deficiency of surfactant, okay? Now, the meconium that gets into the air spaces will inactivate the surfactant and will lead to a deficiency. Free fatty acids in the meconium will replace surfactant phospholipids, changing the lung compliance of that lung. The meconium interfere with surface tension lowering capacity of the surfactant. So surfactant inhibition will decrease lung compliance, increase the CO2, and lead to atelectasis. Therefore, one of the early intervention that you can offer to these babies will be administration of surfactant. This will improve compliance and ventilation, and it will replenish your surfactant deficiency. Okay, surfactant therapy in meconium aspiration syndrome, those especially with moderate to severe respiratory failure, those who are intubated, have led to a decreased ECMO referral. Okay, so prior to the ECMO era, a lot of these babies will stay on a ventilator for a long time. And prior to the surfactant era, they linger. And surfactant administration via lavage or supplement, whatever is inactivated, have led to this improvement in pulmonary function. However, surfactant therapy did not significantly affect mortality in infants with meconium aspiration syndrome, because they're already vulnerable to begin with, because the mortality may not be necessarily related to just pulmonary hypertension itself. But this ECMO referral have led to improvement in the outcome. In fact, majority of ECMO referrals are due to meconium aspiration syndrome. Inflammatory responses are also in operation. Aspirated meconium are associated with pneumonitis in neonates. These inflammatory mediators, and then we give oxygen, these reactive oxygen species, are involved in the pathophysiology of meconium aspiration syndrome, eventually contributing to local injury and further complicating surfactant function. So this chemical pneumonitis picture that we labeled has been nicknamed also as meconium-associated pulmonary inflammation. And I think it's a more accurate description rather than the chemical pneumonitis, because you know, whatever is in the meconium itself, the bile acids, bile salts, and some other stuff, is exactly what we want to prevent from making this particular aspect of this disease escalate. Therefore, the sooner we provide surfactant, we can abort this MAPI or chemical pneumonitis picture. There are also some cytokine or chemokine activation, and this has been shown in animal studies where Meconium intrapulmonary will trigger lung inflammatory cells to express inflammatory cytokines and oxygen radicals, resulting to further lung airway epithelial cell injury and death through apoptosis. They also provoke chemotactic reaction, and also meconium is an extrinsic source of pro-inflammatory cytokines such as this IL-1, beta, IL-6, etc., that may contribute to local inflammation because of the influx of lymphocytes, leukocytes, monocytes, and macrophages that lead to parenchymal injury and remodeling of lung tissue. So what are the risk factors for meconium aspiration syndrome? If you look at the statistics, the Black population predominantly have higher meconium aspiration syndrome compared to other ethnic groups. And during the time when this data has been collected, there's no real genetic reason for this, but it's mainly linked toward the socioeconomic status of the patient population, okay, due to inadequate prenatal care or lack of prenatal care or the use of, illicit drugs. Advanced gestational age, post-dates, post-mature, as explained earlier, higher birth weight. Again, no real explanation here that those macrosomic babies are at higher risk, including meconium aspiration syndrome. But in reality, most babies who are macrosomic are delivered early because they're too big, and they're delivered mostly by cesarean section because they cannot be delivered vaginally. Oligohydramnios is an association. Male, like as I've said with TTN, like any other neonatal pathology, could be a risk factor as well. Or there's an association between male gender and higher risk for meconium aspiration syndrome. It doesn't matter if it's thin or thick meconium. The incidence of mass, there are no real good studies to show whether thin or thick will have the same or one has higher incidence of mass versus the other. So if you look at it in the concept of classifying the neonatal pulmonary disease, meconium aspiration syndrome is considered more of an obstructive disease predominantly rather than atelectatic, although there's some components of atelectasis with this occlusion of the airway with meconium plugging. As you know from obstructive pulmonary disease, the physiology there's increased lung volume, the hyperinflation that we see, the compliance is increased, decreased FRC, increased airway resistance, and increased time constant. So the management of pulmonary management of these babies will be very different from how you manage your RDS. Okay, so if you look at this typical pressure volume curve, your meconium aspiration baby is already operating at a very overexpanded situation where a little bit higher, more pressure will not contribute any further increase in volume, but you're increasing the risk of pneumothorax, okay? As opposed to your low FRC atelectatic RDS baby in figure A. This is an example of a baby with MAS, meconium aspiration syndrome, a chest X-ray showing air leak. This is the lung on the left, and here is air leak, okay? Intubated baby. In general, if you intubate babies and you push the endotracheal tube, it's more likely to develop a right-sided pneumo versus a left. Here you have a left-sided pneumo in a ET tube that is adequately placed. Again, this just shows the effect of initial and expiratory pressure on PaO2, that higher higher PEEPs doesn't necessarily translate to higher PaO2, okay? And this is a pathology slide where, you know, autopsy findings of bronchioles filled with aspirated meconium, okay? The picture doesn't do justice, but some of these are really like this one in a bronchiole filled with meconium debris. And this is the one on the right is more of the peripheral air spaces that contain meconium, but there are a lot of these dark lymphocytes that are reflective of acute inflammation. Again, this is a histology of a lung that has some meconium debris here in the air spaces, some of this, okay? So how do we manage these babies? In the delivery room, you may provide chest PT, although we'll talk about this in a few minutes, whether it really helps or not. Oxygen therapy is really important. You want to prevent pulmonary hypertension. A good pulmonary toilet, lung lavage may lead to, if you do it, it may lead to pulmonary deterioration and lung function. But surfactant lavage has been used instead and may offer some help, okay? And this is where your opening for surfactant therapy will contribute to your improvement. Not always, doesn't always work, but it's an adjunct and it's been shown to be helpful. Like as I've said earlier, it may prevent referral for ECMO because you can manage their ventilatory support better. Here's where we come in, the ventilatory support. Your goal is to correct hypoxia and acidosis by providing better ventilation and oxygenation, okay? Usually when the PCO2 is greater than 60 or your PaO2 is less than 50, it's time to mechanically ventilate these babies because you may start with a little bit of cannula or CPAP or NIMV, but in these situations, I'll have this baby intubated right away. Thinking also that you should avoid high pressures, PPV, because of increased incidence of air leaks, pneumothorax, pneumomediastinum, and avoid inadvertent PEEP because of prolonged expiratory phase in meconium aspiration syndrome due to the ball valve effect, meaning low PEEPs, okay, higher PEEPs may contribute further to your distal hyperinflation or overdistension of the lungs. This picture is old, but it reflects what kind of modes of respiratory support in newborns born with meconium aspiration syndrome, what they need. As you see here, about a quarter will just be managed with room air, meaning maybe a cannula, 21%, okay? Majority will require oxygen. In tandem with whether you provide it with CPAP, with SIMV, those with surfactant, or those with high frequency ventilation and nitric oxide, okay? So the more severe ones will require less majority, of this meconium aspiration syndrome will require less support. Some room air only, and some oxygen support just by cannula. And this is by cannula. Very few with CPAP. Those who are intubated will require sedation, even muscle paralysis, and then surfactant and oscillator and nitrate. So what about respiratory support? Oxygen really is the hallmark. Avoid too much to prevent free radical, oxygen radical damage. Saturation limits 90 to 95. Aim to maintain the PO2 between 50 and 90. Assisted ventilation when oxygen is needed to maintain these limits, 70% when respiratory acidosis or apnea develop. There's no strong evidence to recommend the use of CPAP alone, or CPAP may even increase your risk of pneumo because, again, of the ball valve effect. But we still try to use non-invasive ventilation because you don't really comprehend or appreciate the severity of the meconium aspiration syndrome until you test these types of assisted ventilation, okay? And X-ray is not always reliable to assess the severity of meconium aspiration syndrome. Now, the indications for mechanical ventilation are arbitrary. You start with conventional or synchronized mechanical ventilation when, oftentimes this baby will require a lot of oxygen, greater than 70% to maintain sats above 90. The pulmonary hypertension may complicate this picture, and you see repeated sudden drops in O2 sats, and that's why these babies require sedation and even paralysis. There's apnea, and there's respiratory acidosis, where CO2, it's not uncommon to see it higher than 60, and pH less than 7.25. And this two in tandem will exacerbate your pulmonary hypertension. And therefore, the chance of this baby escalating to a high frequency ventilation support is the next step. Supportive care, you have to thermoregulate them properly, the balance between fluids and electrolyte management, glucose monitoring, make sure they're not hypoglycemic, okay? The use of antibiotics is controversial. Even though meconium is a foreign body that's aspirated in the baby's lungs, if it's sterile, it's supposed to be sterile, and there's no prolonged rupture of membrane, mom had no fever, there's no chorioamnionitis, it may not be needed. But the argument that meconium enhances bacterial growth by reducing host defense, plus it is a foreign body that's a good nidus or a good setting for bacterial colonization and growth, okay? So we use antibiotics in probably 50% of the time. The question is for how long, right? Because that meconium will sit in the lung and it will never be removed until the body will do its own cleaning effect through macrophages. Steroid is not recommended. It doesn't seem to help. But what is helpful is sedation and neuromuscular blocking agents, especially those who are fighting the vent, who are vigorous, and lead to frequent desaturations. Additional therapy, therefore, will include sedation, analgesia, muscle paralysis, so we can manage ventilation better. The use of bicarb to correct acidosis, again, this is more empiric than scientific. It doesn't seem to offer much benefit, but it's just part of your overall management of the acid-base picture. The use of vasoactive drugs like dopamine, dobutamine to increase systemic blood pressure and improve heart contractility could be an adjunct. Again, it's not in every baby, and every baby has to be individualized. Nitric oxide has been a mainstay in pulmonary hypertension. And again, the use of surfactant with nitric has led to decreased ECMO referral. There's variable response to this. And it depends also on the lung areas that can be reached by gas, because if there's some obstruction, some atelectasis, and nitric cannot reach those alveoli, it may not work. You're just wasting some expensive gas to that effect. When available, ECMO should be used for meconium aspiration babies who do not respond to those aforementioned therapies that are listed above. Like as I've said again earlier, that meconium aspiration syndrome comprised the most ECMO referral among neonatal pathologies, up to like 40 to 50%. This is just pharmacotherapy for meconium in a nutshell. Sedation, muscle relaxants, alkalinization with bicarb, antibiotics, vasodilators to support the blood pressure, the pulmonary hypertension, and pulmonary care with surfactant, and then ventilator support, of course. ECMO, we mentioned this. The highest survival rates are seen in patients with meconium aspiration syndrome who qualified for ECMO. With evidence-based approach to prevention of meconium aspiration syndrome and the initiation of better, less invasive therapies, including nitric oxide, surfactant therapy, surfactant lavage with surfactant instead of saline, and various modes of mechanical ventilation, including high-frequency ventilation, all in all together have decreased again the trend of ECMO referral for meconium aspiration syndrome. One last word about NRP, because we see this a lot. We get called to the delivery room for meconium stain amniotic fluid. The postpartum approach to infant born through meconium stain amniotic fluid, the tracheal suctioning no longer is indicated. So whether thin or thick meconium, depressed baby or vigorous baby, you proceed with routine care, okay? Routine care meaning just drying the baby, thermoregulation, stimulating right here, okay? Unless the baby has apnea or gasping and labored breathing, that you escalate your NRP support. Make sure you follow your targeted preductal O2 saturations after birth. And if the baby is missing these thresholds, like at 5 minutes, your sets are still below 80% or 85%, you have to provide oxygen. And in the setting of meconium stain amniotic fluid, consider that this baby has meconium aspiration syndrome until proven otherwise, and of course will be admitted to the NICU. So in the delivery room, there are some options that have been tried before, like chest PT, to prevent accumulation of debris and improve mobilization in the airways. Percussing, vibrating, postural drainage, and theoretically this helps remove meconium from the airways, and it prevents its consequences, and it will improve gas exchange. It's widely performed, but it's, as long as you don't overdo it, because there's some caution here. There's no data that support that CPT in meconium stained neonates, either in the delivery room or thereafter, significantly affects outcome. There are no trials. And there are potential complications of PT physiotherapy, where if you do it aggressively, may lead to pneumo, hypoxemia, arrhythmia, and tissue damage. Okay, so if you have to do it generally, gently, although it's not a big no-no. But some places will not do it because we tend to overdo it. Gastric suctioning. This one I support. I think since babies swallow meconium through the amniotic fluid and it sits in their stomach, during resuscitation, it can get regurgitated and it may end up getting aspirated. So suctioning of the stomachs soon after delivery will eliminate this contribution of aspirated meconium through gastric regurgitation, okay? Especially when you provide positive pressure ventilation. But it has never been evaluated for its efficacy in preventing meconium aspiration syndrome. Like in the chest PT, there are no clinical trials. This is a meconium aspirator. You hardly see this anymore, but when I was in training, we were using this a lot, okay? We talked about this already earlier, the pathophysiology of obstruction, meconium aspiration, mechanical obstruction, surfactant deactivation, atelectasis, shunting, hypoxemia, the presence of air leaks in air trapping, uneven ventilation, and then the development of pulmonary hypertension. Bad news, meconium aspiration will continue to happen, and it will continue to be a threat to many newborns. Right now in our NICU, we have a baby who's on ECMO, and the baby was born with meconium aspiration syndrome, developed bilateral pneumo, had bilateral chest tubes, and was doing okay for the first 24, 48 hours, actually 36 hours. And then this morning, just turned bad, developed pulmonary hypertension, and they had to cannulate and put the baby on ECMO, okay? So you can't predict how these babies are. You know, you don't let your guard down. Even if they're improving, don't wean them aggressively from the ventilatory support. Meconium aspiration syndrome has an estimated neonatal mortality of about 5%, in addition to the short and long-term pulmonary and neurodevelopmental sequelae, particularly the hypoxia, okay? So with all these low PaO2s, you don't know how long they've been exposed to. There's an important long-term follow-up that should be in place if they survive and when they get discharged. Interpartum monitoring, does it really predict like fetal hypoxemia? Although we know that it's a risk factor for meconium stain amniotic fluid and meconium aspiration syndrome. It has questionable effectiveness. Some of these tracings will be like fetal tachycardia, variable or late decelerations, and decreased long-term variability. There are risk factors, so be prepared in the delivery room when you're given this report. We get called for all decelerations. Although there's no increased correlation between abnormal fetal heart rate tracings or patterns during labor and meconium stain amniotic fluid and adverse outcomes, okay? So, you know, just individualize the approach. So the question is, why does the fetus release meconium in the amniotic fluid? If it's released prior to delivery or at delivery, it's associated with adverse outcome. But passage of meconium is usually considered abnormal because it's associated with the following abnormal conditions: fetal hypoxia, intrauterine infections, or gestational cholestasis. But as we know, the more mature the baby, the more advanced the pregnancy, the higher the incidence of meconium stain amniotic fluid, because it just reflects that the meconium passage can be physiologic, and it could be the result of fetal gastrointestinal maturation, as evidenced by postdates and postmature babies having a higher incidence of meconium stain amniotic fluid. Oops, I don't know why this is so, okay, all right. Is there a role of suctioning the nose and the mouth of the baby at the perineum when the head comes out? Because OB used to do this. They suction the head, when the head comes out in a vaginal delivery, they suction the mouth and the nose. But it's been shown that both NRP and ACOG no longer recommend this because it just delays the delivery of baby and immediate intervention of these babies. There was no difference found in the incidence of meconium aspiration syndrome between suction and non-suction infants. And there's no difference in the other key variables, including mortality, the need for mechanical vent, the duration of mechanical vent, or the duration of supplemental use. And this is the reason why NRP and ACOG no longer recommend the intrapartum or of oropharyngeal, nasopharyngeal suction prior to the delivery of the baby. So strategies to prevent meconium aspiration syndrome. The key guidelines involve curtailment of prolonged pregnancy, meaning induce these moms when they reach almost term. Don't let them go past maturity, past their due date, because there's a risk of higher meconium stain amniotic fluid and therefore aspiration syndromes after that. Labor induction with prostaglandins and may be associated with occurrence of meconium stain amniotic fluid. Amniotomy, when they rupture the membranes and release some of the fluid, almost mimicking the effect of oligohydramnios, may increase the risk of meconium aspiration syndrome. And also there's no evidence as to whether expediting delivery because of meconium stain amniotic fluid alone improves outcome. Meaning, if they rupture membrane and then they see meconium stain amniotic fluid, there's no urgency to deliver as long as the fetal heart tracings are good, okay? And amnio infusion has no clear effect on the meconium, on the occurrence of meconium stain amniotic fluid in the setting of oligohydramnios. But in the setting of oligohydramnios, amnio infusion sometimes is being used. And this too has no clear effect on the risk of meconium aspiration syndrome, except in centers with limited peripartum surveillance where the effects may be indirect. Again, if these fetuses are monitored very closely and the fetal heart tracings are good, then the numbers don't necessarily point towards a higher morbidity. So long-term outcome consequences, they really boils down to a couple of things. It relates to the mode of intervention. Prevent hyperventilation because of the link to deafness, okay? The effect of meconium later on in survivors as far as their pulmonary airway reactivity is concerned remain to be established. So to summarize, just to allow you more time for questions, meconium aspiration syndrome remains a significant morbidity. 3 to 4% of pregnancy with meconium stain amniotic fluid will develop meconium aspiration syndrome. Aspiration may occur before birth or during the birth process. And therefore, you know, suctioning the trachea after birth is no longer recommended because the aspiration may have already occurred in utero. Meconium aspiration syndrome is an important cause of mortality in otherwise healthy term or post-term infants with a case fatality rate exceeding 5%. And airway suctioning of the neonate may reduce but not eliminate the occurrence of meconium aspiration. With that, I allow you 10 minutes for questions, okay?